Welcome to the HFMA Talk podcast, the podcast for NHS Finance. I'm Alex Hunt, Content and Social Media Executive at the HFMA. In today's episode, we're bringing you a recording of a recent webinar from our series, Exploring the 10-Year Health Plan and What It Means for Finance. In this session, Phill Wells, Deputy Chief Financial Officer, Strategic Finance at NHS England, offers a comprehensive overview of the plan, with a particular focus on the implications for finance professionals working across the health service. The session is chaired by Simon Crowther, Acting Chief Executive at Oxford University Hospital's NHS Foundation Trust, and it is followed by a Q&A. So let's hand over to that session.
I'm Simon Crowther. I'm Interim Chief Executive at Oxford University Hospitals. We are delighted to have with us today Phill Wells, Deputy Chief Finance Officer, Strategic Finance at NHS England. Phil's most recently been the CFO at North Central London ICB and previously CFO and Executive Lead for Procurement Estates, Facilities and Clinical Engineering at Hamilton Health FT. And before joining the NHS, Phill spent 16 years in the civil service in a number of policy analysis and finance roles as well. So Phill will explore the finance-specific chapter of the plan, breaking down how the NHS intends to manage resources over the long term to support sustainable services, to support transformation as well, which is something we all badly need to look at and do, and improve outcomes as well. Let me hand over to Phill. So Phill, over to you.
Simon, thanks very much for that introduction. Appreciate it. This sort of feels like a back to school presentation, actually, as a kind of, this is what's coming our way. This is what's going on. These are the things and challenges we're going to have to address. If I can get even a tenth of the way, Simon, to answering your kind of question that you've set about what are we going to do about all this, then I'll be pretty happy with this presentation. But mainly it's to give you guys a greater sense of what's in there if you hadn't had a chance to digest it over the summer. And then hopefully in the Q&A just to open up about some of the challenges it might present, some of the opportunities it might present as well. So I am going to focus on the finance chapter, but let me say a few things about the 10-year plan more generally first, if that's all right. So published back in July, this is the government setting out its ambition for health in England over the course of the next decade. And we were at pains to discuss this during the development of the plan with colleagues in DH and across government, that this is a health plan. It's not an NHS only plan. So it does contain in it things that we need other government departments to work with us on. And the NHS obviously makes a significant contribution to that. It has in it three key messages about the shifts that we want to see in healthcare in England, which you will know very, very well. It describes the shift from treatment to prevention. It describes a shift from analog to digital, and it describes a shift from hospital to community. I remember sitting with Sally Warren, who was one of the key authors behind the plan a few months ago as we were presenting some of this stuff into the DH. And she used a phrase that stuck with me as I've talked about the plan, which I think is quite important. Those three shifts, she said, are not in themselves novel. They're not new. We've talked about them for many, many years in the health service. We all know they are the things we need to achieve. What would be new about this plan and what those that have drafted it want us to see is that this gives us a path to actually doing them. And our job in the finance function as an enabler to these is to try and figure out the ways and means to make them happen with our colleagues delivering the frontline services that we talk about in the plan. So a few other things just by way of context. This is a 10-year plan. So under no means is anyone expecting all of the things that are in it, and there's over 300 of them, in it to be delivered tomorrow or indeed next year. But by the end of the decade that this plan covers, we should expect to see health being delivered in the ways described in this plan. And then the second thing that we should note as the finance community is that we have done as best as we possibly can to make sure the content of this plan is aligned to the settlement that we achieved at the spending review for health. And I'll say a little bit more about that in a second. Chapter 9 is the one that you should have sticky labels all over. It's the one that talks about the financial architecture and the things that will change as a result, and indeed is already forming our thinking as we move into the planning round for next year and the years beyond. I'll say a bit more about that too. So as I begin speaking to what's in it, I'm going to give you one task after this, if you don't mind, and that's to read it. It's not a heavy read, but we as finance people should know and should care about what is being said about the thing we are supporting the delivery of. So if you haven't already had a good read of the health plan, make yourself several cups of coffee, find a bit of space, read a chapter a day for the next 10 days, and you'll get through it. That's my challenge to you. These are the 5 foundations for the new architecture we describe in the plan. There are 5 things in it that we have been working on and working with people on. They are a new approach to NHS financial management. There's a shift to longer term planning. We are talking openly about sharper incentives within the system, moving to something more like a should cost model of care rather than what it does on average cost, and that being what we pay. There's a chunk of work around making the geographic distribution of resources across the NHS fairer, and then there's a chunk of material on the new approach to capital. What I'm going to do now is take us through each of those in a little bit more detail, and then try to illustrate for you where work has already started inside NHS England and with colleagues across the service, and then the things that we still need to do and we'll come back to. Right, so first of all, a new approach to NHS financial management. In this section in the 10-year plan, authors describe the NHS as having developed an addiction to deficits. And I think that's really symptomatic of how our approach to financing the NHS over the last decade has been perceived. Government, and particularly colleagues in the Treasury, look at us as constantly wanting to have more money in order to achieve the things that we want to achieve. And part of that's about the scale of the problem. Part of that is a question back to us about, are there ways of doing things better, more efficiently, more productively over time? And we can talk at length about productivity and COVID in the Q&A if you like. What's set out in the 10-year plan is a really clear objective about transparency across the financial regime so that deficits are understood to be deficits where they exist and what's being done to address them, but that which has a clear escalation process and a clear intervention where performance is not on track or indeed performance is lost over time. I think we'd all welcome that, actually. I think there's something really positive about calling a spade. And I think there's something really positive about knowing that the NHS has to live to its means. So I'm not sure too much of that is contentious. What is difficult, though, is actually then going on to achieving it. What the plan sets out specifically are a few things. One, and some of you will be living and breathing this already, around deficit support funding. So the plan says that in 26-27, we will phase out deficit support funding altogether. That gives us some margin by use of the word phase, because it may not all go, but that will be a decision that we take as part of setting allocations in the planning round to come. Separate to the plan, but critically linked, is we also introduced in 25-26 some changes to the way DSF would be paid. When Elizabeth, Nikki and I joined NHS England, we agreed that we would not pay DSF to those systems who were failing to meet their agreed financial plans. So there is a cash incentive in effect to stick to your plan, achieve the plan, if you are a system in support of in receipt of deficit support funding. So change is already afoot there and more to come. Second, I mean, we say this all the time, so this is nothing new, an expectation that there is full compliance with the planning ask of the NHS. What is new in the document is it does reference a further strengthening of those responsibilities and accountabilities if this does not come to pass. So I think specifically in the document, it refers to the fact that, say, the local government obligation to set balanced plans is much, much stronger than the one that we see for NHS organisations. And the document does make passing reference to the fact that that would be considered in the future if necessary. Personally, I think as a public accountant, we've got a job to do that's an obligation on us to try and live to the means that we've been given and to make the best of the taxpayer funding that we are provided with. So again, I don't think there's much contentious in there, but the delivery of it will be hard, particularly where there are historic deficits and underlying challenges to address. Possibly the most exciting part of this chapter for me, though, is the reference to productivity improvements. And I'm not going to turn this into a productivity presentation, but I think it's well known across the NHS, and certainly I would hope among colleagues in finance, that the NHS is still not back to its pre-pandemic level of productivity. So it's still not delivering per unit of input the same level of output as it was before COVID. That's something we're going to have to fix very quickly, because otherwise we will not address the elective challenge. We will not provide access to primary care in the way we've described. We will constantly be dealing with challenges of not having enough money to meet the expectations of government, and more importantly, the patient. So we will set, and have set in the spending review, an ambition to achieve 2% year-on-year productivity across the NHS. And I don't just mean acute, so I mean across the entire NHS. And doing so gets us back by the end of the spending review period of 28-29 to those pre-pandemic levels of productivity. That's an essential ingredient of living to our means. So it's not an optional extra, it is a requirement. And I think us in finance, through planning, need to look really carefully at what that means and make sure that we are confident our organisations have the means, the programmes, the wherewithal to kind of go on and deliver that. We will shortly publish the estimate of productivity for 24-25. That is a positive estimate when you see it. It's technically a national statistic in development because it changes the way we've assessed productivity compared to how the ONS have been doing it. So it gives us, we think, a much more accurate assessment of productivity. It will include measurement for community and mental health services, and we've got some more work to do on primary care. We will again send you out the benchmarking of opportunities, and I look forward to the many months of dialogue that will follow those things. But they're interesting to look at. They may be slightly wrong in places, but they are still indicatively pointing you at the areas where you should look to get better, because either others are doing it and there's variation, or indeed you have historically done better in those services than you are doing at the moment. And we will also, and have been, working on support tools through things like workforce and agency reduction to support you locally to try and deliver those productivity expectations. I feel like I'm labouring it, but this is not going away. We are meeting with Number 10, with the Treasury, with the Department. Andy Haldane, a former governor, Bank of England Monetary Policy Committee member, has been looking at this with us. We are going to have to focus on this as a community, and I think we've got a really positive role in finance to play in supporting our colleagues to improve productivity across the NHS. So that, the new approach to NHS financial management. And hopefully some of you are even starting to feel some of these things in your interactions with the centre, with regional teams and with commissioners as well. Second one then is on a shift to longer term planning. So again, this is not too contentious in the quote, but it was the best one I could find. So for too long, we've lived with short term fixes and short term funding. I think that's true. I mean, I've been in the NHS now for 8 years. I think I've been through at least 12 planning rounds, some of them 6-month cycles, some of them year cycles. It's no way to run a 200-odd billion pound business. So we are breaking that cycle this year, and will publish guidance, or instructions as they may be called, shortly, requiring commissioners and providers to plan over a 3 to 5 year horizon. We asked for it and we've got it, and now we've got the opportunity to make the most of it. That planning, in a sense, builds on the spending review settlement, where we now have 3 years worth of revenue and 4 years worth of capital. It should allow us to make better decisions. It should allow us to make service transformation choices. It should allow us to plan trajectories towards the kind of financial sustainability positions that we all want to see for our organisations. So I found this personally really quite welcome that it majored in the finance chapter. I think there's no way to run a health service on annual planning cycles, and we did need a longer horizon to work to. What you will have also hopefully spotted is that in response to this, we published something called a planning framework in August. That's kind of, Elizabeth describes this as getting match fit. I apologise for those of you that don't like sporting analogies, but it's actually quite a good one. Pre-season training started early. We pointed out things that we thought, in talking to colleagues, were good practice. You know, how have the best places got themselves ready for good planning rounds? And it's by doing things like good understanding of demand in their populations, good understanding of capacity, early starts on things like service transformation. So we set out some guidance and some frameworks for you to work with and some tools as part of that. So I hope they have been useful. Our intention is to send out the instructions as early as we possibly can. I don't yet know when that date's going to be because, as you well know, these things require quite a lot of clearance with colleagues in the centre, but expect it to be earlier than it normally is, and certainly a lot earlier than it was last year. Alongside that, then, with your kind of, this is what we need to achieve as a service over the next 12 months and the next few years. The other thing that I should point out that was in the 10-year plan was this requirement over time for a 3% reserve of annual expenditure for one-time investment. Now, I've sat in some of your positions over the years, so I know that at the moment will feel like a pipe dream, but there's nothing wrong with that being our ambition for the future, because actually, if we do want to make genuine transformation happen, it will require investment. That investment's only going to come from the current allocation, so we've got to find a way to create a bit of headroom over time to allow us to make the kinds of changes that we need to make. Third bit, sharper incentives. So familiar to all of us, behaviours are shaped by the financial incentives that we create. So we've got to get these right. It sort of completely stands to reason. How money flows has a profound impact on behaviour and culture in the NHS. Certainly back in the days of PBR, that was true. I think it's equally as true under the days we've had of block, and certainly under the current system of the aligned incentive contract world. So the 10-year plan recognised this and said that what we need is the right incentive structure and the right financial architecture to enable the kind of change we want to see happen, those three shifts. And a number of key components. These are not exclusively it, but as far as I'm concerned, nearly all of these are underway in terms of work across NHS England and with many of your colleagues in commissioners and providers. So first of all, we said we would deconstruct block contracts. What does that actually mean? Because it didn't say, for anyone thinking it did, that we're moving back to PBR. It said we need to understand what those block contracts are buying. And those block contracts, remember, cover UEC, they cover radiotherapy, maternity, community services and mental health services, and a few other bits besides. So really, we need to understand, what are they buying? With what degree of efficiency are they buying them? With what degree of productivity are they buying them? And are we getting the right things for the money that's in there? So that work has started. We've already had good engagement from 7 trial systems within the regions. We're expecting returns from all systems at the end of this month to allow us to understand what people think are in there. Some bits are telling us things we probably thought we knew around UEC in particular. Some things are showing us that the data is not in a very good position, and it might take us a bit longer to reset those particular elements, particularly for community and mental health. All of it is important, though, and we really do need to understand how we use the amount of money in those block contracts to really drive the outcomes that we want to see for patients. Second, the 10-year plan talked about the use of best practice tariffs. So this is very much thinking about how much things should cost rather than using the average construct for what it currently does cost. So the National Payment Scheme consultation, which will come out very soon, will start to talk about introducing 30 new best practice tariffs next year. So we'll meet the 10-year plan commitment. Those will be around things that we've used best practice tariffs for in the past, around shifting inpatient to day case, and building on the work that's been done by Right Procedure, Right Place. And there'll be more of this over time as well, particularly then as we start to think about new incentives that we develop to drive neighbourhood health, which is the third element in the 10-year plan. And the key driver there is answering the question, what structure of financial architecture do we need that encourages us to keep people out of hospital and particularly out of UEC? So how do we keep people healthy in their home, in their care home, in their own community, rather than them turning up probably far too late in the development of their episode, and support them to stay out of hospital, where typically they will stay for too long and probably don't need to be. And one option that we've been exploring on that's mentioned in the 10-year plan is this thing called a year of care payment. So thinking about a construct that pays for an entire patient for an entire year on a capitated basis that is then used to support them for all their various health needs to stay away from the front door of a acute hospital, where they'll end up being tested with, as I say, expensive treatments and long stays, often unnecessarily so in some instances. And then fourthly is that we want to listen more to what patients are saying about the quality of the service that they've received. So the Secretary of State in particular was very keen to see us develop a mechanism by which patient feedback ultimately determines how much a provider is paid for the service that they have provided. So the so-called patient power payments will need to be developed carefully because we don't want to be destabilizing. But we have got some ideas and thoughts about those. And again, we'd welcome your thoughts about how we can use the financial incentives to drive higher quality across our services. So an important chapter, this one, and one where I think a lot of work has already started so that we can get things off the ground into 25, 26. Fourth area was fairer geographic distribution, and the provocative statement in the 10-year plan is that the current flow of resources does not always match where the highest need is. That is not that provocative, it's true. If you look at the distribution of resources, there is very much a distance from target apparent across the NHS. That's why we have convergence and pace of change, because we know that the money is not quite in the right places for historic reasons. What we are keen to do is find a way to move towards target allocations for systems much faster than the current pace of change and convergence formulas would suggest that we do. That's important because it means that the population needs are being reflected in the allocations that are being given to commissioners to buy healthcare services strategically into the future. A number of things were part of this chapter. The Secretary of State has asked the ACRA group to review the resource allocation formula. That will be a technical exercise, probably take about 12 months. But we need to make sure that it's reflecting particularly the needs of coastal and rural communities, given recent reports by the Chief Medical Officer. We are also looking at how we do address that distance from fair share allocations as part of the changes to the convergence framework over the course of the next few years, alongside that deficit support removal that I mentioned. And as you will know, if you're in an acute hospital, the amount of money in the elective recovery fund remains really important to you in terms of delivering the elective change. I'm not entirely clear, though, that the wait list for patients is distributed in a fair way across England. So we need to think about making sure that that elective recovery funding is going to the right places so that they can efficiently and productively deliver as much work as is needed to get back to that constitutional standard that we need to meet across England, not just in one or two places of England. And then the sentence that I've been hearing since I joined the NHS back in 2018, the government talks in the 10-year plan about continuing to move growth of spending away from acute hospitals and into out-of-hospital services. That should be an ambition for all of us if we are serious about neighbourhood health. So we need to find ways of helping all the different parts of the health service work together to achieve that over the next few years. I'm going to finish, though, with the new approach to capital, which is the flip side of all of this, because without good estate and good infrastructure, both digital and physical, frankly, all this is for the birds. The 10-year plan talked about the need for a really ambitious proposal around capital, and that we use that new regime to drive longer-term infrastructure planning. So I certainly remember in my days of working in NCL ICB, quite how frustrated it was to be only able to plan capital over a relatively short-term horizon, when frankly you knew some of the schemes were going to take longer than that horizon to actually deliver, let alone produce the benefit in the business case underpinning them. So a few things. You will hopefully have clocked that the capital budget grew by 3.1 billion from last year into this. It continues to grow, although albeit at flat real rates through the spending review period. And we have 4 years of the capital settlement. So there's very much an opportunity to make sure that we get allocations out that cover all of those years and allow you to plan sensibly across a multi-year horizon. We want to see, as part of the 10-year plan, more control of this devolved to local systems. There will still clearly be larger schemes that will need national or indeed regional support. But wherever possible, local systems, providers and commissioners should be making decisions about how to spend an amount of capital to both maintain and shift the asset base of providers. And of course, we all get stymied by the capital approvals process, and the Treasury have given us greater freedoms on that as part of the spending review settlement and linked to the narrative in the 10-year plan. There is a section on there in the 10-year plan that I would encourage you all to read, because it does remind us of the flexibilities that already exist within the capital framework for the NHS. So have a look at that. It's worth reminding you about things like disposal receipts and all that kind of stuff. And then finally, I'll finish with possibly one of the most difficult bits to agree as part of the 10-year plan, which was our argument that the amount of publicly available capital will never really be big enough to achieve what we need to do for the transformation of the health service. So we are actively looking at where we can drive new models of finance into the health service. And the 10-year infrastructure plan, a separate document, but again, worth a flick through if you get through the 10-year plan in a decent time frame. It does specifically note neighbourhood health centres there as an area where the government would be willing to consider public-private mixed investment, not necessarily a return to full PFI, but something of a new model, a bit like they've been done in Wales, for example, to drive both private and public investment into those centres. We would obviously like it to do more than that, and we continue those discussions with the Treasury. But there you go. That was whistle-stop, quite close to a whistle-stop tour of Chapter 9 of the 10-year plan. I think I've pulled out most of the financy bits, Simon. There is tons more stuff in there about forms of organisation and other things. So wherever colleagues want to go now with the Q&A, I am more than willing to take us. Thanks very much.
If you want to dive deeper into the 10-year plan and what it means for healthcare finance, the HFMA annual conference is just around the corner. With a jam-packed programme full of amazing speakers and sessions covering the key shifts outlined in the plan. This is your chance to discuss the key political, operational and financial challenges facing the NHS, and to come together with colleagues from across the UK to celebrate the best of healthcare finance. Accommodation packages are filling up fast, so book your tickets today by clicking the link in our show notes. We'll see you in December. Now, back to the episode.
Fab. Thank you, Phil. Really appreciate that. I think you absolutely did cover an awful lot there. And actually, one thing we'll just thank you for again, which I think has been a theme over the last few months from you and the team, is the transparency and honesty. I, for one, appreciate the straight talking. We all know we are in a difficult position, so let's face this up and do what we need to. Right, okay. Thank you everyone for all the questions in the chat. There are quite a few. I'll get to them. I'm just going to selfishly ask one of my own first, and just so the audience accept me, I am an ex-CFO, by the way, so I'm allowed to ask one. And Phil, I just wondered, because I think you've rightly talked about the need, and I'm chief exec of an acute hospital, and you've rightly talked about the need to move at pace, care closer to home, and that comes with it with some of the incentives or some of the mechanisms you've mentioned. And my question's actually one about culture, because having worked in finance in the NHS for lots of years, we've got a tendency to, you talked about productivity, and I know probably what we'll do once we get all the benchmarking is argue with you for 6 months over the data and accuracy. I also know that we have a lot of conversations about moving funding and not costs. And I just wondered about your thoughts on maybe some of the cultural change we need to achieve in the finance profession to go along with some of the service change.
That's a really, really pertinent question, I think. So first of all, thank you for the comments about how we're trying to engage. I think it's just really important to have an open, honest conversation. We've done some really good engagement events with the CFO community of late. They've been really positive. I've enjoyed them. There's been oddly some laughs as well as some tears in some of them. So we are definitely finding a good balance. But the engagement we've had on those, so we are running work streams on each of those 5 areas. And we've had some tremendous amount of volunteering come in just to pitch in some thoughts, because frankly, I'm not sure we know all the answers. And I think it's actually okay to say we don't know the answers. And it sort of speaks to the culture you're describing of, like, we need to be really curious in the finance function about what we see in our data. So you're right, there's a very big risk that we'll send out some productivity packs and I'll get, 1,300 emails saying, how dare you, this is wrong, that's not quite right. I would challenge us when we receive them, to be curious about them. So even if it is wrong, is it totally wrong? Or is it just maybe, a decimal point or two out wrong? Or is it actually still directionally enough for you to go and have some conversations with clinicians, with ops colleagues and say, is there something in this? Should we be doing something different? How can I help as the finance person, the finance team? How can I help us understand more about what this is saying? Because the problem's not going to go away by arguing. The problem's going to go away by exploring possible solutions, testing things, good data analysis, good insight, going and spending time in a theatre and just watching what happens. Speaking to the porters, because frankly, they know everything that's going on in the hospital. Nothing happens without them. So get out of your desks, get out of your rooms, get back into the hospitals, get back into the community centres and go and see what's going on and help your team change its culture, become more curious about what's going on. Fine, there'll be things that are wrong in the data, fix them. Don't just accept it, but take responsibility then for trying to get on with it and get us out there with you. I'd love to come and spend some time in different places to see what's going on. If you've got best practice that's really worked and you've, turned an inefficient set of theatres into the most productive thing in the world, bloody shout about it so we can come and find out how to make it happen across lots of different places.
Fab. Thanks, Phil. I just absolutely support you on the getting out there as well. I've always thought whenever my kind of career, whenever I've visited a service, spoke to a bunch of clinicians, I've always done my job slightly differently following it. So I'd absolutely support you on that. Right. I'll go to a few in the chat, Phil. I think the audience probably needs appreciation, though, that some of these, there is no right and wrong answer, and it might be more of an opinion or a view. But there's one I just want to ask you about in terms of the 10-year plan, just your thoughts on how it's future-proof to changes in government and the political environment, because I just know that's been asked nationally as well. So just views on that, Phil. I know there's no easy answer.
Yeah, I don't write for The Spectator or for, the New Statesman, so, goodness only knows. This is this government's plan. So for as long as this government are in post, it will be this document for the next 9.5 years that they refer back to. Now, there is a moment in this horizon that may change, but, not a political commentator, so whatever happens, happens. Will it get rocked from time to time? Will personalities change? Of course they will. But this is the plan that agreed by Number 10, the Treasury, the Department and other government departments, because it went round for cross-government clearance, that they've signed up to, that underpins their manifesto, the plan for change. So for as long as this government's red, this will be the plan that we work to. If the government colour changes in future and becomes some slightly different colour of brown, blue, yellow or another, then sure, because they'll have different political priorities. But in the public service, you work to the government of the day, and that's what this government set out for us to achieve. Yeah. And to be honest, actually, I'm going to say one other thing, Simon. The underpinning outcomes for it are about constitutional standards that haven't changed for a long time. There'll be no one on this call that thinks more than 92% of people should be waiting more than 18 weeks. In fact, there'll be a lot of people on this call like me who think that nobody should be waiting longer than 18 weeks or indeed anything like 18 weeks at all. But, we'll one step at a time. So quite a lot of the underpinning metrics, the underpinning ambitions for outcomes, will be true of most flavours of government, I would have thought. Yeah.
Thanks, Phil. Agree. And actually, you said something earlier in presentation about the 3 shifts being nothing new as well. We know they're the right thing to do. So I'd entirely agree with that. Okay, a couple more from the chat, and colleagues, forgive me. There's a few long questions on the same theme, so I'm gonna try and get the theme right. But there are a couple of questions, Phil, around how is the tension recognised, and your thoughts on how we manage the here and now, and having to do the very much we all know we've got to deliver this year on the constitutional standards. We've absolutely got to do safety and quality, absolutely have. But also deliver the money. So how do we do that versus the long-term aspirations, and just any views you've got on how we manage that? And I guess if I could just add a kind of nuance to it, Phill, what would you be looking for from the service as well in terms of a live conversation on that to help you at the centre, help us shape this?
Yeah, so I think a couple of things, and most of these, I should say, actually are personal views. I'm not. There'll be various moments I can speak on behalf of NHS England, and sometimes you probably just want to hear what I think personally. So this is one of those ones that I think personally. What's the counterfactual? Like, what's the alternative? That we just carry on running really hard for 6 months, 12 months, reset, then another 6 months, 12 months, and nothing changes. So the answer is that we have to do things very subtly differently. We have to raise our eyes above the next horizon, the next budget report, the next return to NHS England, and we have to break out of a cycle which I don't know. Quick straw poll, if it's even possible. Who's happy planning to a 12-month cycle? I mean, it's just not planning at that point, is it? It's kind of delivering. So the idea that we encourage people to lift their eyes up above the horizon, stretch out, what they want to do in terms of service transformation, I think it's freeing a little bit, So I can envisage a situation, personal view, where, provider A can't quite hit the plan that they need to set in terms of either a deficit or RTT or something else at year one. But the plan for recovery in year two feels so committed, so strong, so good, so well thought out that, that might not trigger the kind of intervention it would have done under a 1-year horizon. Now, I'm not saying that will pan out, but that's the way I would want us to look at it, because some of these things require you to stand up capacity or to bring new consultants in, and that takes a bit of time. Equally, we can keep staring at things that we violently agree on in terms of left shift, but until we actually start making them happen, which will take more than 6 months, we'll never actually see greater investment in the community. We'll never actually see prevention taking shape. We'll continue to see more people than we know how to service come through the front door of UEC, no matter how many times we reconfigure the damn thing. So this is really an opportunity for us to break out of those molds. And again, as finance, lend hand into the thinking about what it will take to make those things happen. Lend it into me and to Nikki and to Elizabeth. What do you think we prevent from happening by the rules we come up with? But equally, what's not happening locally that you can influence with the might that you've got of the finance function? It has a massive role to play here. There'll be no decision taken in the next 10 years as part of this plan that doesn't involve you giving good, solid financial advice that enables it to happen. So, sometimes it's hard to get a bit depressed. It's easy to get a bit depressed in finance, but you're going to be at the centre of things for a long time, and have the ability to influence what healthcare in your area looks like for a long time to come. That's massively exciting.
Yeah, thanks, Phill. Totally agree again. Absolutely why we're here, isn't it? I'll pick a couple of questions now that are probably a bit more factual for you. So what engagement have you had from clinicians, ops lead and other professions into the finance chapters?
Yeah. So lots of different people have contributed over the time. We didn't actually write the finance chapter. We were contributing to it as well. So it's not our writing. It's the DH team's writing. But certainly as it was developed, there was a huge number of conversations across, all sorts of teams in NHS England, which obviously included, Chief Nursing Officer, Chief Medical Officer functions, our own. Where we could, we were testing things with CFOs and CEOs to see how they would land in advance. What we've done since then is equally as important, actually, which, as I said, is those 5 workstream engagements where we have just a huge amount of input from the CFO and CEO community. We sought volunteers for those. We've had, loads of people contribute. I think we've had at least a meeting of each of them, if not a couple or 3 in certain instances of the sharper incentives workstream, because it's so bloody complicated. So we're getting tons of input on that. And in particular on things like deconstructing the block contracts, we've again been using a group that includes chief operating officers, ICB and provider teams to lend a hand and help us and learn about it as we go, because it is a really complex thing to do. So loads of engagement. There's always room for more though. So if there's an area you think we're missing, then again, just give us a shout.
Yeah, thank you. I wonder sometimes if there's an opportunity for you to shout a bit more about the input and engagement you've had, actually, Phill, because again, having been there, it's easy once you get the guidance to sit back and think, well, somebody's done this in a darkened room, and
Yeah, sure.
pretty much always I've known that's not the case. So maybe there's something about how you at the centre just kind of make that clear. Far be it from me to say, but yeah.
And there is a bit of that will happen. I think Jim Mackey and the national team are bringing together some of the CEOs, ICB and provider, and some of the primary care leadership together in the middle of September. You might actually be going, Simon.
Yeah, that's right.
And I think there's an update planned on all the 10-year plan work streams there, and in particular a focus on what engagement has actually happened. Almost like proof of you're not sitting in a darkened room doing this alone, are you, NHS England? And no, we're not, is the answer.
Absolutely. Thanks, Phill. A couple around CDEL, if I can. So an issue around private-public finance arrangement is that we need the CDEL to cover the lease or purchase of an asset. How can we address that? Is it part of the conversation? And there was another one as well, Phill, if I can tag it, around potential for anything longer than one year's worth of CDEL to facilitate that longer-term planning.
So let's do those in reverse. So annual CDEL is a construct of government finances. It's all slightly boring, so let's not spend our time talking about that. But is there always going to be, unless the Treasury change it, will there be an annual CDEL limit? Yes. What the 10-year plan talks about is us trying to use that as flexibly as we possibly can. And there is a bit of freedom from the Treasury to try and do that. But it doesn't involve complete fungibility from one year to the next. Like, we can't spend nothing this year and then, twice as much next. That doesn't work in terms of the net public sector borrowing requirement work that the Treasury have to do. And it starts to screw up how much the government is borrowing from one year to the next. And then it starts to affect bond rating. All sorts of other stuff happens. There's, for the economists, of which I was once one. So there'll always be an annual requirement. What we've got to try and do is make it as flexible as we can, possibly at the margins. But when you're talking about margins of 14 billion quid, you're talking about actually, reasonably big money. So that's quite important. The PPP/PFI thing, you're right, whoever has asked that question, does still need quite a bit of work. But it is directionally something we are very interested in pursuing. The Treasury still need quite a bit of convincing that it's the right thing to do at a scale that, we might have ambitions to do it. But the conversation's open. All of those things that you've described are in that dialogue and are being worked through. And at some point we'll have something to test, I think, and then we'll see, the proof will be in the pudding. Can we make it work? At what scale can we make it work, and in what arena can we make it work? But the infrastructure plan said that, we can start to work on proposals around neighbourhood health centres. Personally, I'd quite like to see us, work at a trial basis in some of the areas we know we need big investment in. Some of the hospital environment. I mean, both mental health and community and acute environment too.
Thank you for that, Phill. So, a question around equal focus on waiting times for mental health, LD and autism. And I guess if I can just add a link to it about the work nationally ongoing around data quality and consistency of those services, because I know from previously working in them, that's part of the issue with that.
I 100% agree. And again, from my experience in the commissioner at North Central London, you can see how big a problem, and particularly adolescent and children's mental health, is going to be in this country over the next 20 years. So it cannot be just about physical health. It must not be just about physical health. And so I think you're dead right that the kind of equality of weighting of the mental health performance targets, community service performance targets in the acute is really important. And they interact with each other. I mean, for those of you in acutes, there'll be countless times you can think of, being on call or colleagues being on call and somebody phoning saying we need to help somebody find a bed for a patient that's now in the wrong environment, getting the wrong support at the wrong time in their particular crises. So yes, I 100% agree. And an example, I know how long it takes. Well, from personal experience, I know how long it took to get a child's ADHD assessment. That's not good enough. And the NHS is letting people down if it thinks that that's the standard to live to. We've had a number of discussions recently about SEND. There's a proposal from DFE coming out shortly as a white paper about how across government it needs to do more for the education of those with special educational needs. And it's another one of these cross-government areas where one department can't solve the problem alone. So I think that's really powerful that we're working with DFE on that stuff. There's a lot more to do around mental health schools teams. There's a lot more to do about whether the MIS is being used appropriately and well enough, because there's a lot of money in this and we're possibly at risk of not getting the kind of value out of it that we really should be. So again, can keep coming back. There's a bit of a theme running through this like a stick of rock. Finance here is so important. Like, what are you getting for the money? How much value is it driving? What are the outcomes that it's generating? It makes the system work. We just got to make it work better.
Fab. Thanks, Phill. I'll get through a couple more as well, and then I'm selfishly want to ask another myself. So, year of care payments, are they envisaged to be similar to personal health budgets? Or maybe just a bit more around kind of how that might work?
Yeah, no, I don't think so, because I don't think it will put quite the power into the patient's hands that a personal health budget does, for example. But this is more about saying what we actually want for a payment that combines, a number of different things. We would expect that patient to now be able to be looked after for a year and kept away from the most expensive interventions that otherwise the sort of the fractured system would mean that they slip into. So I think it is different. The proposals are still pretty early in development because it is really quite complicated. But what we're principally trying to achieve is an answer to the question of how to keep people away from the UEC environment that really don't benefit from being there. Now, that's not to say we want to keep people away who should come, because that's, it's there, use it when it's needed, obviously. But, if you're an old person in a care home, chances are, for some of your visits to A&E, you could have probably stayed in your care home and been treated differently. You would have been more comfortable. Your recovery would have been better. Your mental health would have been better as a result. You wouldn't have stayed away from your friends and your family for as long. So all of these things contribute to your overall well-being, and we need to figure out a way of doing that. And year of care payments is one of them. I'm quite personally interested in pathway payments as well. I think that would be another interesting approach for different areas. And then there's the age-old question of, are we getting best value out of the vast number of follow-ups that we are spending money on? I was looking through some numbers the other day. We spend more on follow-ups than we do on the entire of the primary care system.
Scary.
If anyone would like to put their hand up and tell me that they think every single outpatient follow-up is a valuable experience, come on, let's have that discussion.
Yeah. And I guess, Phill, part of the challenge there goes back to your point about actually there's a really legitimate need for a clinical conversation there. A lot of this is behavioural, isn't it? So as finance professionals, do we get out there and have those conversations with clinicians, show the data as well? In my experience, clinicians love data.
Yep. Yeah, I agree. And that's, some of it, as we were talking about culture in the finance function, some of that's going to be cultural in the clinical community as well. And that's fine. Can't just wash it away or accept it just because it's cultural. You have to take that on too. So why is there risk aversion to discharging a patient who probably doesn't need to come for that final follow-up? We need to address some of that stuff and understand it. And that's what I mean about being curious. Like, what is it that's in the mind of a clinician when they're thinking that through? Understand that. That'll help you do your job better, help me do my job better when I was doing it.
Yeah, agree. Thanks, Phill. So I'm gonna do the last couple. So if anybody has got a really burning question, do please put it in the chat. So is there anything in the plan about social care and the problem caused by no criteria to reside patients?
Not enough. I think Secretary of State himself has acknowledged that there's more to do on social care. So no, Louise Casey's doing her big review of the social care system at the moment. I would absolutely expect more on this to follow. I don't know what's coming, but again, I've been around it with you. It is a challenge, and it's a challenge that we need to address with local government together. And quite clearly, the extent of financial challenge in local government is just as much, if not even greater, than we've got in the NHS. So it's going to be a knotty problem to fix, but it is definitely driving a flow problem in our hospitals. And again, it's kind of, whoever's asked it, great understanding of your own environment, because the front door is as important as the back one. And it's about equalizing those as best we can and getting best value. And again, getting people into the right place for their recovery.
Thanks, Phil. And I'll do the last one now, because that's felt like a bit of a grilling. I'll do the last one. So when you were just talking then about, we've talked about the cultural change needed and the clinical discussion. So again, how do you envisage kind of education and drivers to change clinical decisions being developed? And if I can tag on if I could, how are you working together, I guess, as a national team about aligning all the incentives around the behavioural change you need?
Yeah. So, I really well is the answer, but I would say that, wouldn't I? Because I wouldn't want you to think anything different. But, I've been to the NHS England executive quite a few times since I joined here now, which has only been 5-6 months. If only I knew then what I was letting myself in for. And I've seen, Magana lean, who's one of the medical team, lean in, really significantly into the challenges we face on workforce and agency use and better job planning. She's demonstrated to her profession that really caring about resource use is an important part of their responsibilities. And that the more they can do it, the more they are therefore addressing risk in the patient population. And I think that's the connection that I've seen her make wonderfully in the way she's contributed to those sessions. Duncan Burton too, in the CNO function, really leaning in with Elizabeth and us to try and figure out how we can, best educate nursing around use of resources and making sure good decisions are being made that are value for money at the end of the day, as well as representing high quality patient care. It feels like we've got a real joining of, financial value and quality at just the time we need it. Because one can't be at the expense of the other. We need to do both simultaneously. And in all the work I've done in the civil service and while I've been in the NHS, it definitely feels like those two things are achievable. They're hard and they take time and effort and energy. But it kind of, for me, comes back to the point I made right at the start, which is if you've got a finance function that's really curious about what's actually going on with the numbers behind its spreadsheets, then that insight can really drive improvement. And that's our job for the next however long it takes to fix this.
Perfect answer to end with. We couldn't have scripted that any better. So I just want to thank you, Phil, actually, for not only the presentation, but some real kind of candid and honest and constructive answers as well. There's some clear messages here for me as a finance profession that actually can give us optimism, because just to reiterate a couple of themes Phil's mentioned, this is about us getting out there. This is about us shaping, changing to get that balance we need over the quality, the performance, and living within our means. And ultimately this comes down doing the best for our population, doesn't it? Which is what we're here for. So hopefully you've got that from today.
Thank you to Phil and Simon for that session. The Exploring the 10-Year Health Plan, What It Means for Finance webinar series is ongoing until November 2025. You can catch up with the sessions like the one you just heard and sign up for the rest by registering using the link in our show notes. That's it for this week's episode of HFMA Talk. Thank you for listening. Don't forget to subscribe so you never miss an episode. And if you enjoyed the show, we'd love for you to leave a 5-star rating on your favourite podcast platform. See you next time.